All right, hello and good morning. It's so nice to be here, nice to escape the heat from Arizona. So what I'm going to talk about today is bone marrow transplant. Now, bone marrow transplant is not necessarily going to apply to everyone in this room for a number of reasons. First of all, it's primarily for people with myelofibrosis. So with essential thrombocythemia and polycythemia vera, we generally do not transplant patients like that in that situation because it's not necessary. And so when I discuss this, a lot of this will really apply to a very select population, and even in people with myelofibrosis, it's not necessarily meaning that you need a transplant right now. So I just want to preface it with this so that when we kind of go through all of this, it's understood sort of the applicability of it. So first of all, what is bone marrow transplant? What it involves is high to intermediate doses of chemotherapy, followed by hematopoietic stem cell infusion. And now hematopoietic stem cells are kind of the stem cells that live in your bone marrow that produce all the blood in your body. So there's a small number of them, and basically they ultimately divide, become the red blood cells, the white blood cells, all those things that really help you exist as a person. When we give chemotherapy, the goal of chemotherapy is to get rid of any last bits of disease, as well as suppress your immune system, because when I give you somebody's new immune system, you don't really want to kick it out right away, which was what would happen if we didn't suppress your immune system. The new immune system, or the new blood system, is not going to have the mutations, it's not going to have the disease, which will mean it's a healthier blood system. And the new blood system will contain an immune system. This immune system can fight off underlying disease. So if you have any last bits of cells left behind, this new immune system will go and get rid of them. And that's the real reason we do this, is because we want to provide some lasting protection against the myelofibrosis coming back. Now, when you hear about bone marrow transplant, it's important to know that autologous stem cell transplant, a person uses their own cells. This is not an option for people with myelofibrosis. We use this for patients with lymphoma and myeloma are two of the bigger indications, as well as a number of other indications. But any type of blood disorder, it doesn't really help to put your own cells back in because they're just going to cause the disease again. Allogeneic is when we use donor cells. So allogeneic stem cell transplant or bone marrow transplant, however we refer to it, is when we use somebody else's donor cells, put them into you to try to fix your blood system, or give you a new blood system, I suppose is better. So there's a lot of different names that you'll hear. So we hear peripheral blood stem cell transplant, hematopoietic stem cell transplant, bone marrow transplant. These all refer to that same concept of taking somebody else's blood stem cells and putting them into a patient or to you to help create this new healthy blood system. Now, when we talk about bone marrow versus peripheral blood, this refers to how the stem cells are collected. So the stem cells need to come out of the bone marrow, and there's two ways to do this. Either number one, we directly go into the bone marrow and extract them. So that's like getting a bone marrow biopsy for whoever the donor is, but on both sides about 50 times. It's actually done under general anesthesia. And more commonly, we collect it by giving a medicine. The medicine kicks the stem cells from the bone marrow to the peripheral blood, and then we can collect them in a way of similar to like dialysis. Basically, we take the blood out, collect out the white blood cells, which have the stem cells, and put the rest of the blood back in the other arm. So this is sort of how that looks, the peripheral blood stem cell collection. You see there's a guy sitting there. He has an IV in both arms, and one arm, it's actually, I think this one has just one IV. But in one of these tubes here, they're taking out the blood, and in the other tube, they're putting back in the blood after we've taken the white blood cells out of it, which contain the stem cells. And as I said, in a bone marrow harvest, we literally bring a person to the operating room, put them under general anesthesia, and use the backside right above where their bottom is, and basically put a needle in to collect liquid parts of the marrow, which also contains stem cells. Now, at the end of the day, we get a bag that looks like this. It's very anticlimactic. If anyone's ever received a blood transfusion or seen anyone receiving a blood transfusion, it looks kind of like that. And this is what's infused into a person when they get a bone marrow transplant. So there's no surgery involved, except for maybe doing the harvesting. And when people say, what do you do? And I say, oh, I do bone marrow transplant, they're like, oh, so you do surgery? No, I do not do surgery. I basically have to come up with high doses of chemotherapy to give somebody these cells. And then more importantly, deal with complications afterwards. So you might ask, why? What should I want to do this to myself? Should I pursue a clinical trial instead? And this is a conversation I have with a lot of patients with myelofibrosis, and also being an MPN doctor in addition to a transplant doctor, this is something that I think is a good question, an interesting one, and one that's certainly worth having a discussion upon. So what are concerns that people have about transplant? When they start to read about it, first and foremost is, what's the quality of life going to be? The financial implications of it can be fairly significant. You need a caregiver. So for people who are used to being on their own, you have to have somebody with you 24/7, which is a huge challenge for some people. I know it would be for me. Graft versus host disease. This is when that new immune system, I want it to go and attack the myelofibrosis, but sometimes it goes back and it attacks healthy tissue. So when we did a survey on patients with myeloproliferative disease, less than half of them were referred for transplant, and that probably reflects even hematologists and oncologists have sort of an internal bias. And then out of the patients who went to transplant referral or got a transplant opinion, less than half of them went to transplant. And, and again, that's based on a lot of these concerns, which are very valid concerns. And I think it's important, and there are people studying what's the thought process around going to transplant and where people's reservations come from. And as I said, the other considerations, physicians are human, they'll have biases. Transplant physicians sometimes even have biases. Hematologists, and then when you go on blogs online, I think these blogs are a double-edged sword. On one hand, it's great to see how many people are going through a similar experience and feeling that, sort of not feeling so alone because this is such a rare disease, but on the opposite side of that coin, sometimes people share a lot of information that can be extremely scary, and that their experience doesn't necessarily mean it's going to be your experience. And that's really an important thing to keep in mind. So when we look at what about clinical trials and other medical treatment, this is an amazing time for myelofibrosis. We have now, instead of just one JAK inhibitor, now we have 3 JAK inhibitors and another one which should be coming out on Q1. There's 3 new drugs in clinical trial that may actually help the disease more than just symptom control and spleen management. So this is a great time for myelofibrosis in terms of just this wealth of treatment coming about. However, although these treatments are great, and I think that they potentially may change the trajectory of people with myelofibrosis, they're not curative yet. Bone marrow transplant is a curative option. Now, this is a very individualized decision, and I think that's one of the reasons that I enjoy being an MPN doctor and a transplant doctor, because you really have a conversation. You have to take into account people's values. You have to provide a good enough education. People need to understand what they're getting into so they can make an appropriate decision about proceeding or not. So when do you see a transplant specialist? It's really, really important if you have myelofibrosis, especially if you're somebody who may eventually need a transplant, even if maybe you never would, but eventually need a transplant, it's always good to see a transplant physician. And the reason why is there's a lot of things to plan for, and plus, wrapping your head around this whole process of undergoing a bone marrow transplant is huge. So having that time to sort of process it, really think about it and make the appropriate decision is really important. And unfortunately, a lot of times people, start thinking about a transplant and it becomes such a ginormous monster in their head before they even meet me that then it's sort of you're breaking down all those preconceptions and trying to really explain what it involves. There are a lot of resources needed for transplant. You need a caregiver. Sometimes this is not a medically trained person. This can be a spouse, it can be a friend, it can be a child, it can be a parent. Almost anyone can fall into that caregiver category as long as they're willing to be with you and then help. And it's not like after a transplant somebody can't take care of themselves. You can clean yourselves, you can take a shower by yourselves. But if anything changes, and it's not very common that people get really sick in such an acute fashion, they need that person to do something. But it is really important just to have somebody there to hold you accountable. I think one of the common things I think about is somebody will say, oh, I have a temperature. Okay, great. Most of the time you'd say, well, I have a temperature, I'm not going to do anything about it. Well, a lot of times your caregiver will be like, no, we know we have to go in, let's go. So it's really important to have somebody to also hold people accountable. The financial implications can be high, even though insurance covers transplant, and insurance even covers lodging for the most part so that you can be near a transplant center. It still is, people time out of work, medications have copays, hospitalizations have copays, so there is a financial implication to doing transplant. And a lot of times it's good to have that heads up, especially if you're on Medicare and need to get a Plan D or medication coverage, which sometimes people don't have. And then lodging, when you do get a transplant, you need to live near the transplant center. Now, if you're lucky enough to live in a city that has a transplant center, then you can stay at home. But if you're more than an hour away from the transplant center, or half an hour, depending on the program, ours is an hour, you actually need to have lodging and be within an hour of the transplant center because of the different complications that can happen after transplant. And this is through day 100. So you're in the hospital for about a month of that, and so it's about 2.5 months after you get out of the hospital that you need to have lodging. So these are all really important things to have in place, and it's good when you kind of have a heads up that they may be coming. So who should you see? It's really, there's more and more of us out there who are really, understand transplant for myelofibrosis, which is a slightly different animal than transplant for a number of other different diseases that we do. So the timing of transplant is really a shared decision-making process. It's not something that I say this is, there are situations where I'll say you absolutely should get a transplant now, or you absolutely should not get a transplant now. The timing of this is really a discussion, a conversation to try to help people understand when is the right time to proceed. Sometimes it can be years away, sometimes it can be a couple of years away, sometimes I say, we probably should go in the next 6 months. But no one answer is correct for everybody. Even if you don't get a transplant at that center who has a person who really understands myelofibrosis and transplant, it is always good to get an opinion, just because, again, when you take, and having been a transplanter for my entire career, I know how transplanters think, and it's kind of a hammer and a nail. And it's like, okay, well, you have this disease, you need a transplant. But actually having sort of that discussion on the nuances of it, I think, can be very important. Plus, I think a lot of transplanters view myelofibrosis kind of like myelodysplastic syndrome, which is another bone marrow disorder. And they're kind of different animals, and there are different things that can happen after transplant that it's important to be aware of, as well as certain aspects that can be beneficial. So what to expect during a bone marrow transplant? Number one, bring somebody with you. And bring a tape recorder, or record on your phone. I guess tape recorders don't really exist anymore. But bring a recording on your phone, because you get a lot of information. It's incredibly overwhelming, and you really want to make sure that 2 sets of ears are hearing things, and have a recording is sometimes even better. It's always polite to ask let your doctor know that you are recording them. Be prepared to be scared. There's a lot of scary stuff about transplant. It's a difficult process. It's a tough process. That's why I don't say, well, geez, you have polycythemia vera, I'm going to put you through a transplant. No, you have to. It's a select group of patients, and you have to be sick enough to require one, which kind of sounds a little strange. But it is a scary process. As I said, if you can, record the consultation, and if you have any doubts, get a second opinion or a third opinion. It's really, when you go into this, even if everything is done absolutely 100% correctly, things can still go bad. And you need to make sure that you really feel like you understand the process before you commit to it. So when should you get a transplant? It's reserved for higher risk patients. And we'll talk about how we define somebody's risk. It's really important to know your risk. So understanding the nuances of the disease is a really important thing. And specific timing of it can also, in certain circumstances, be tailored around life events. Like, for example, I had a patient who said, well, I really want my kids to get out of school and do it during their summer break, because then it'll make things easier for us. And we were able to accommodate that just because of the nature of the disease. Sometimes that's not possible, but when, sometimes people say, oh, well, my kid's in college, I want them to finish the semester so they can come home and help. All sorts of things that we can sometimes account for and adjust for. So how do we define risk? So there's a lot of different risk scoring systems, and they all have limitations. So even though, when you look up these risk things online, they talk about, oh, well, this means this survival and this means that survival. When we look at this one, this is sort of the oldest one, the Dynamic International Prognostic Scoring System. This was made before Jakafi was even approved. All of these were published before anyone had real good access to Jakafi, which we know has changed the face of how people can live with myelofibrosis. So they have limitations in predicting survival. Nonetheless, I think there's some basic tenets to the disease that are clear by this in terms of, we know anemia is a risk. We know that high white blood cells and blast percentage can be a risk. We know that, age can contribute to risk. We know platelets of less than 100 contributes to risk, and there's multiple studies that validate all these separate, symptoms and blood tests, et cetera. But again, when we look at the absolute number of years of survival, we have to take this with a grain of salt. So when you look at that online, and you can find it, of course, where it'll say, oh, this is what we expect the median survival. And understand, when they tell you median survival, that means half the people are still alive and half the people aren't. So that doesn't mean like you have a ticking time clock, like, okay, it says my median survival is 10 years. Okay, well now it starts 10 years from now, I'm gonna drop dead. It doesn't happen like that. It's something that it gives you an estimate where half the people are alive and half the people aren't. So maybe less than that, it may be more than that people would survive. And as I said, these survival estimates are really not too accurate at this stage in the game. So clarification of risks. So, this one. Okay, so when we look at the clarifications of risk, anemia is when your hemoglobin is less than 10. So your hemoglobin could be 11, it's gonna show that you're anemic, but that doesn't necessarily convey the same risk. Another thing that's important about anemia is if you're put on Jakafi, you will become anemic in many cases. That does not carry the same risk as just having anemia as a baseline part of your disease. Thrombocytopenia, low platelet count, platelets of less than 100. Leukocytosis, a white blood cell count greater than 25. The upper limit of normal is 10. So there's a huge point there where you have an elevated white blood cell count, but you don't necessarily have the risk. Blasts, these are immature white blood cells. If you look up blasts online, you're gonna see that they're associated with leukemia. If you have blasts in your blood, that does not mean you have leukemia. They have to be present at a percentage of greater than 20. If they are present at greater than 20%, then that is the definition for leukemia. But most people with myelofibrosis were able to really sort of get a handle on what's going on, and we see what's going on before people get to that point. We can't always prevent it from happening, but it shouldn't kind of come out of nowhere. An abnormal karyotype, this is sort of looking at chromosomes, which, if people remember, they used to do amniocentesis, where they'd stick the needle in a woman's belly and take out the cells and make X's, and in case of men, Y's. It's looking at those chromosomes and seeing if there's any sort of changes that don't exist, like maybe part of chromosome 3 flips around, or maybe part of chromosome 11 goes to chromosome 9, and they switch back and forth. So these are things that we can detect with a bone marrow biopsy. And then there's constitutional symptoms, which is fatigue, weight loss, decreased appetite, night sweats. Fatigue is a tough one. If fatigue is the only constitutional symptom, I don't necessarily count it. I mean, don't get me wrong, fatigue is a very difficult symptom to have, and I'm not dismissing it, but fatigue is also so multifactorial, and it's actually one of the hardest symptoms to really treat. So there is this spectrum timing tool that was created, and that was looking at using the DIPSS score. And then, so if you're low risk, you're green, yellow for intermediate 1 risk, intermediate 2 risk is red, orange, and then high risk is red. And then usually when we want to start to have the conversation is somewhere between here. So when you think about transplant, I kind of like to think of it on this continuum. And so this is when you get diagnosed with the disease. And so this is DIPSS lower intermediate 1 risk. And then there's intermediate 2 risk, and then high risk and advanced disease with organ dysfunction. You need to be thinking about transplant sort of at this stage in the game, probably more even before you hit DIPSS intermediate 2 risk, although sometimes people are diagnosed there. And when to do the transplant, you don't want to do it when you're too low risk or it's too early. You could take away, people die from transplant. You could be taking away years of life that we don't want to take away. We don't want to wait till you're really sick, because then the transplant course isn't really optimal. And for the most part, we think that right around this DIPSS intermediate 2 risk is probably about where people should get a transplant. But there's other factors that we think about. This is not a perfect system. So if you go to your doctor and you say, well, geez, I'm DIPSS intermediate 1, but they're still recommending transplant, how can that be? There's other things that convey risk Number one is your driver mutation. The driver mutation is what contributes to formation of the disease. There's 3 of them that we know of. There is JAK2, MIPL, which is, I can never remember the full name of it, MPL, and then calreticulin, or CalR. There are cytogenetics, which we talked about are the X's, and molecular mutations. So when we look at the driver mutation, we see that the majority of people will have the JAK2 mutation, a fair number will have calreticulin, MPL is quite rare, and then there's a subset that have no mutation, no driver mutation. We know that if you have calreticulin, that's actually a really favorable risk thing. We know that if you have none of these mutations, that puts you in a higher risk category. So again, when we look at that intermediate, 1, intermediate 2, and high risk, sometimes this might shift how we think about it a little bit. The cytogenetics, there are some abnormalities that we see. Now, it's important to remember when I talk about genetic mutations, this is not a mutation that you've inherited, nor is it a mutation you pass on to your children. This is a mutation that happens as your disease develops. It's a really important point because a lot of times people get really worried, will this pass on to my children? And that could be a whole nother discussion, but in essence, these genetic mutations, the JAK2, are not genes that are passed on from parent to child. And then there's next generation sequencing, and this is a type of testing that looks at all those mutations, some of which that Dr. Ritchie had spoken about in her talk. And this is a test that can be done on peripheral blood in people with myelofibrosis, is often done when people get a bone marrow biopsy. And what it does is it tries to help understand, convey higher risk. So we know certain mutations, and you can see there, the ones that are circled, these ones convey a higher risk, meaning that we think that people who have those mutations may have a more aggressive disease course. And this can be important and helpful in trying to figure out that timing about transplant. The good news is that the disadvantages of high-risk disease in terms of these mutations in cytogenetics likely can at least and mostly be overcome by a transplant. So if you have these high-risk mutations, there's a whole lot of studies out there, none of which necessarily agree with one another. But the take-home message is probably transplant can overcome the majority of it. So again, when we talk about when to do transplant, when people have these higher risk chromosomes or mutations, they kind of tell me when something starts to change, I go quicker rather than later. So I might not say you have 6 months to wait. I might say, you know what, things are looking different in your marrow. We know you have these high risk mutations. We should go sooner. And in good risk mutations, maybe you can even wait a little bit longer. I don't know. I probably should change this slide and move that down a little bit. But we do know that now, if you have these high-risk mutations or bad chromosomes, we actually start thinking about this at the intermediate 1 risk. So again, this is a lot of information. It's very hard to sort of interpret all this and put it into context, but these are really important discussions to have around the timing. When you meet with a transplant doctor, is to try to understand where the risk is and really incorporate all of these into that discussion. And again, unfortunately, none of us have a crystal ball. We can't tell you exactly when you should go to transplant and when it's going to work out best and what's going to happen when you get it. But at least it's something where we can provide a little bit more insight into what's going on. So other things to consider: symptom burden, what type of symptoms people are experiencing. The use of ruxolitinib, which we're still defining how that plays a role in transplant. I think we know that having it before transplant and having a good response seems to benefit outcomes. There's even some thoughts in the practice I've started as actually treating with low-dose Jakafi or ruxolitinib throughout the transplant and stopping it when people engraft, just because we know that it suppresses those immune things, and we don't really want you getting this whole new blood system and this massive immune response. Transfusion dependence, that really bumps people up in risk. If somebody's transfusion dependent, I usually say this is telling me that it's time to be thinking of transplant. And you also got to think about what gives you the points. So since this is an MPN and women's conference, I wanted to sort of discuss some women-specific issues. And again, not all of these apply to everyone who's getting a transplant, but they're important to think about. Things such as fertility preservation, the fact that many women who get transplanted go into early menopause. Osteoporosis is a thing that many women have, but can be exacerbated by transplant, and then post-transplant sexual difficulties. So fertility preservation can be done through several different ways, or 2 different ways pretty much. And it's tricky in patients with myeloproliferative disease because one of the ways is you actually harvest the eggs by doing similar to what's being done with a cycle of IVF. Now, if IVF basically involves jacking up your hormones to the degree that you produce lots and lots of eggs, and then they pull the eggs out of you and either fertilize them or put them in a freezer or do something with them. Problem is, those hormones all can contribute to developing blood clots. So that's something that needs to be discussed very carefully with a fertility doctor and a hematologist sort of together before proceeding. The other ways, they've actually come up with ways to sort of take out ovarian tissue and freeze it, and it gets far into an area that I don't understand how they process it, but that is a way that we found that can help, and this actually can be done a lot quicker and doesn't involve a lot of hormones. So again, if there's somebody who's young, and we do unfortunately see young people with myelofibrosis who need a transplant, seeing a fertility specialist is always something to discuss, and that's one of those benefits of going early to see a transplant doctor, because that gives you time to figure that all out. Early menopause is unfortunately very common after transplant. Depending on age, some women can have return of ovarian function, but it's very common to have premature ovarian failure, and many women don't recover ovarian function after transplant. So monitoring FSH can help determine ovarian function, although in some patients, FSH is one of those hormones that kind of makes estrogen go. So if there's no estrogen, the FSH goes really high, telling us that you're probably not making enough. And so monitoring FSH, it can go up after transplant, transiently, and then come back down. And again, it varies from patient to patient. I have had patients who have gotten pregnant after transplant. It's extremely rare. It depends on sort of the chemotherapy given beforehand. So I always tell patients, this is not birth control. You can't rely on this, even if you're not having menstrual cycles, to be birth control, because people can still get pregnant. But it is something that it's very common to have early menopause and have all the symptoms associated with it. And then the risk and benefit of hormone replacement has to be discussed with a physician. I know at Mayo, we have a women's health group, and they're extremely good at sort of helping navigate some of these issues with patients. And then it's, of course, exacerbated if you have somebody who had a blood clot because they had an MPN. And so where does that put us? And I don't think we know the answer to that at this point. Again, not something that we can prescribe in a generic way, but something that's worth knowing about. And osteoporosis, it's very common. Like women have a higher risk of it anyway. And unfortunately, skinny white women have even worse complications, higher risk of osteoporosis. Why does this happen? Chemotherapy, medicine that prevents graft versus host disease can weaken the bones, and glucocorticoids, which are medicine that we use to treat graft versus host disease. So it's really important to have bone mineral density monitored on a regular basis, take calcium and vitamin D supplementation, maintain a healthy lifestyle, so exercise. I can't speak on how importantly exercise is in any stage of life, whether you have a disease or not even. And then there are different medical treatments for osteoporosis, such as reclast or Prolia, which are frequently used to help try to preserve or restore bone strength. And they keep coming up with newer things that help with bone strength, because I think osteoporosis is such a widespread problem. And then sexual issues after BMT. And I think that there is going to be a talk a little bit later about GYN issues following transplant that will probably go into this in greater depth. But over half the women following transplant will have sexual difficulties, and this is something that a lot of times transplant physicians don't discuss. This can be due to vaginal dryness because of being postmenopausal. GVHD can occur in the vaginal area, chronic graft versus host disease. Hormone imbalances are very, very common, not just because of menopause, but also when we give somebody steroids that can really fluctuate their hormones. Anxiety and depression after transplant. There's an enormous amount of, it's a difficult process to go through, and then when people are survivors, sometimes there's still a lot of stress after that is not fully recognized, because people are like, well, you're getting better, why are you stressed out? And that's sometimes when the full gravity of the situation hits them. So anxiety and depression can affect that, and then body changes. So when somebody goes through a transplant, their body changes, they lose a lot of muscle mass, and they can get it back. People do get back to a normal life after transplant, but it definitely can change that. So the body image can change how people view themselves and their own feeling of attractiveness. So it's really important for patients who get a transplant to talk to their providers, to really make sure that this is being addressed, and see a women's health specialist, because there are ways to address these issues. but it is something that is extremely common and probably more common in women than in men. So just to summarize, bone marrow transplant is a curative option for myelofibrosis. None of us know the best time to undergo a transplant. It's really a personalized decision and something that really involves a good conversation with the transplant provider. Women do have specific issues following transplant, especially in survivorship. And then it's really important, just to summarize, to know your risk, to really understand the myelofibrosis, the risks associated with it in terms of identifying the correct time to move forward with transplant. Because again, there's not a perfect time for anybody, but understanding and having a better knowledge of your disease really gives you the power to make the appropriate decisions. And that probably applies to any aspect in any disease. But for myelofibrosis and transplant is something where I think it's extremely important. And that is it. I think I ran over, so I apologize. And but that is the end of my discussion. So hopefully